Hi, this is Dr. Desmond White, gastroenterologist and hepatologist. Today I want to share one patient. This patient is an elderly gentleman. He had atrial fibrillation, that means irregular heartbeat. And he's on a medication called anticoagulant. Anticoagulant, they're different brand. Last time we used something called warfarin, but now we have better medication like Xarelto and many others. These are very strong blood thinners, stronger than the normal blood thinner like Plavix or aspirin kind of thing. So they make the blood very thin. So we normally give it to people that have atrial fibrillation, irregular heartbeat, so that in some people with AF, atrial fibrillation, when they have an irregular heartbeat, there'll be turbulence in the heart, they can form a clot, the clot can shoot up to the brain to cause a stroke. As a matter of fact, a lot of strokes are caused by embolus, that means the blood clot from the heart, that because of irregular heartbeat, turbulence or other factors, the clot go from the heart through the blood vessel, go to the brain and block the blood supply. So AF is a major cause of a stroke. To reduce the risk of a stroke, most cardiologists or a neurologist will give the patient a blood thinner like an anticoagulant. So they thin the blood, so even though there's turbulence in the heart, they don't form a clot and they don't cause stroke. Then there are many, these are the pros of anticoagulant, but there are many risk factors there are many adverse effects of anticoagulant. The major one is bleeding. I mean, when you thin the blood, they don't form a clot in the heart, they don't cause a clot, they don't cause a stroke. Then, if you have a fall down, the brain may bleed, it will pull out a teeth, you have a surgery, the wound may not heal, the wound may keep bleeding non-stop. So bleeding is one of the major complications from anticoagulant. So I got this elderly patient that's on anticoagulant, but he had been feeling tired. And his blood count showed that he's anemic. Anemic means the hemoglobin is low. And when his referring doctor tested the blood, tested the stools, he found that there was blood in the stools, what we call positive fecal occult blood testing. So an elderly gentleman had blood in the stools, is anemic. Of course, we think about, can he have something bleeding in the gut? Can he have an ulcer in the stomach? Can he have a cancer in the stomach, a cancer in the colon? Can he have a polyp, a blast polyp in the colon that causes the bleeding? So because when we see fecal occult blood positive, it means that they have some bleeding inside. So all these things go through our mind. So came and see me because his referring doctor, a kidney doctor, and his family doctor referred to me to say that, hey, this gentleman is anemic, he had blood in the stools. I think maybe something bleeding inside, maybe something benign like an ulcer, or it can be some cancer. I think this patient needs a scope. So when I saw the gentleman, I told them I agree. I think scope is indicated in the sense that I say that, uncle, you are anemic, they found blood in the stools, there's a possibility that something is bleeding inside, we should do a scope to check. For normal people, I offer them the risk of a scope being less than 1 in 1,000. It's quite a safe procedure. I do it almost every day. But for this gentleman, because he's on an anticoagulant, the blood thinner, I told him, if I do a scope for you, there's a risk of bleeding. If I see a polyp, I can't take out the polyp, because if I take out the polyp, the stop won't heal. They will keep bleeding non-stop and your life will be in danger. So in order for me to take out a polyp safely doing a colonoscopy, do a biopsy safely, if I see anything abnormal, I have to stop his blood thinner, stop his anticoagulant. So I told him, check with the cardiologist, minimum 3-4 days, okay? So before the scope, we have to stop the blood thinner for 3-4 days so that the blood is no longer thin, it's of normal thickness, normal coagulative, and then I can do a scope safely. If I see anything abnormal, I can cut it out and without the fear of non-stop bleeding. But the patient have to accept 2 extra risks. I mentioned when I do a colonoscopy, the risk is less than 1 in 1,000 from perforation, from bleeding. But for him, there'll be 2 extra risks. The first is I need to stop the anticoagulant for maybe 3-4 days prior to the procedure. During this period, his blood will become less and less thin, become back to normal, so that I can do the scope. But don't forget, for him, he had atrial fibrillation, he had irregular heartbeat. We use a blood thinner to prevent a stroke. So when we stop it, the prevention effect will be gone. So I told him, during these few days, your blood will not be as thin as before, and you have irregular heartbeat. So you run a risk of a stroke during these few days. If I do a scope, I do a polypectomy, remove a polyp, I will reintroduce the blood thinner maybe 1-2 days after the procedure. Sometimes when we reintroduce the anticoagulant, the blood thinner, the part that I do the polypectomy may bleed, so there's a risk of rebleeding. In other words, there's a risk of a stroke when we stop the anticoagulant. There's a risk of bleeding when we reintroduce an anticoagulant. This is in addition to the normal risk that we see in normal people. So I told him and say that, sir, you have to accept the risk of a stroke when we stop the anticoagulant, accept the risk of bleeding when we reintroduce anticoagulant after the procedure. If you're happy to take the risk, we're happy to proceed with the scope. There are patients that they want to find out exactly what happened to them. They want to know the bottom of the truth. They say, go ahead to do the scope. I will stop the medication at your advice, and I will accept the risk of a stroke and the risk of bleeding for the maybe 5 to 7 days of period, a few days before, a few days after the procedure. But there are also patients that will say, I don't want the risk of a stroke, because if I have a stroke, I don't die, my life is ruined for the rest of my life, no matter how long it is. So I want a zero risk of a stroke. So I would then have to tell them, if you want zero risk of a stroke, that means we cannot stop the blood thinner, then I will not do the scope for you, and we will not know what happened to you. Of course, we can do a CT colonography to look at the colon, but CT colonography, the CT scan, can miss a small lesion, cannot see the stomach, and if CT colonography see anything abnormal, I still have to do another colonoscope and a gastroscopy to check. So to sum up, I told the patient he had 3 options. Number 1, do nothing, maintain the status quo. Number 2, stop the anticoagulant for 4-5 days, do the scope, reintroduce the anticoagulant 1-2 days later, but accept the risk of stroke and the risk of bleeding around the procedure. Option 3, no need to stop the anticoagulant, do a CT colonography, look at the colon, and take it from there. Unfortunately, none of the option is perfect, okay? You either take a risk or you don't take a risk. You take a risk, that benefit. You don't take a risk, there's also a harm. So how? And this patient is elderly. He had 2 sons, and they don't live together. So I told the patient came with the elder son. I told the elder son, please talk to your mother, who's the wife of the patient, and talk to your sister, talk to your younger brother, who is also his children, and come to a consensus. Do not just proceed to do something that when complications happen, you start blaming one another. So life is not perfect, life is not easy. As a doctor, our job is to analyze the situation, provide options for the family. For this particular case, I leave the consultation open-minded, open-handed. I ask the patient to think about it. I ask the son to talk to the younger brother and get back to me after the discussion. Well, this is life. This is Dr. Desmond White. Thank you for listening.